Next, we have Dr. Scott Livingstone, and we have a great opportunity today to hear from someone from both the doctor surgeon perspective, but also the patient perspective, as he's actually received multiple liver transplants himself. So Dr. Scott Livingstone is a hepatobiliary and multi-organ transplant surgeon at Dalhousie University and is the first person to actually receive a liver transplant and then later become a transplant surgeon. He practices with liver, pancreas, kidney transplantation, and his personal journey with 3 liver transplants informs his care for patients. So I welcome Scott to come up and speak. Thank you.
All right, thank you. So this is probably less detailed than the other talks, but that's okay. I think the objectives were basically to tell you exactly what is a liver transplant, who needs one, how do we evaluate people for liver transplants, and what life could be like, with a liver transplant. So first off, a liver transplant is where we take out your old cirrhotic looking liver and we replace it with a nice healthy looking liver from a donor. And in Halifax right now, we only do whole organ transplants. So we only do transplants from cadaveric donors, but it is possible to receive a live donor liver transplant. We do have plans in the next few years to start up our own live donor program, but places like Toronto, Edmonton, Montreal, they do live donor transplants, and that you can receive either the left lobe or the right lobe from somebody. Typically, they're most commonly actually used for pediatric patients, and they've really kind of revolutionized the treatment of pediatric individuals who need a liver transplant. So when we take out the liver, like we have to take out the whole organ. It's not like a kidney transplant. You can go back. Yeah. When you do a kidney transplant, you don't have to put it in where your kidney was, which is way back here. You just put it in the groin because your kidney takes all the blood systemically and then just cleans it. You just hook it into your bladder. But the liver is one too big to put into your groin, and B, it has like it has a dual blood supply, and it also secretes bile, which you have to get back into your GI tract. So we actually have to open you up, take the whole liver out, remove it, and put in the new liver in the same spot. So, okay, you can go to the next slide. So transplant statistics. Since in 2024, these are wait list deaths in Canada. This is just in Canada. So in Canada, in 2023, there were 526 liver transplants. The volume has been increasing over time. There were 200. There's still, though, about a 20% death rate on the wait list. So there was 217 people died and 8 kids died while waiting for liver transplant. So we still don't have enough organs available for all the people who need a transplant. And therefore, it's a bit of a limited resource. And we only transplant people when we actually think that they really are going to need it. And then we also have to transplant. We have to put in considerations as to where is the benefit going to be the most? Who's going to receive the most benefit from an organ? Obviously, if we had organs for everybody, we would be transplanting more people. Okay, you can move on to the next slide. So as I described, we remove your old liver, we put in the new liver. I do have to make new connections when I do this. So there's this big vessel behind your liver called the vena cava, and that drains all the blood from your legs and everywhere all the way back up to your heart. And we do have to sew the liver in. You can do it different ways. You can cut out the vena cava from the recipient, but that's more of a technical issue. I have to make a connection between the portal veins. So this is the vein that drains all the blood from your GI tract that goes through your liver, gets cleaned before it goes back up to your heart. So we have to make that connection. The liver also receives blood from an arterial supply, which supplies the bile ducts and keeps them healthy. So we have to make a connection there. And then we have to also make a way for the bile to drain. So usually, in most cases, we'll just divide across the patient's bile duct, and then we'll sew the bile duct from the liver to the new one. Sometimes, for certain conditions, we don't do that, and instead of hooking it up to the patient's bile duct, we'll bring up a piece of small bowel and hook it up to the small bowel. So it's a very, very technically demanding operation, but it's very, very physiologically demanding operation on patients. So a liver transplant takes about 5 to 6 hours in general. And oftentimes, most people that are having a transplant do have cirrhosis, and they do often have decompensated liver disease, meaning the liver is not doing all the jobs that it would normally. One of those key jobs is your liver is involved in making clotting factors that helps keep your blood from just bleeding all over the place. So often people do bleed quite a bit. They usually need a blood transfusion. People are usually quite sick when they come in for a transplant, but not everybody. So, okay, we can move on to the next slide. So types of transplants, as I mentioned before, you can do whole organ transplants. You can split the liver down, and we will do that sometimes if we have a recipient who's quite small, who otherwise wouldn't be able to fit a whole organ from a donor in. We might actually cut the liver down so it'll fit. We have done that recently here. We had a donor, and there was a pediatric recipient in another province that they wanted to use part of the liver for. So we had a fairly small recipient ourselves. So they came and we divided the liver and the donor, and we took half of it and gave it to our recipient, and they took the other half and gave it to their pediatric recipient, and people did well. So, and you can do live donor liver transplants, which I've mentioned. There is obviously a risk to the donor. It's not very high, and donors are screened very carefully to make sure they have to be very, very healthy. And so that risk is about 0.2 to 0.5% in terms of dying. There have been a couple of donor deaths in North America, not very many. I don't think there's been any in Canada, but it is a risk. So typically, most common situation is a parent or somebody else is donating part of the left lobe of the liver to a kid, and that's much less risky. The most risky one for the donor is actually to take out the right side of the liver, which is the biggest. Wait, you can move on to the next one. So what are the risks of liver transplant? Death. So the risk of dying from a liver transplant in and of itself in the first within hospital is as high as 15%. I think it's less now, to be honest with you. I'd say it's probably between 5 and 10%. The risk of dying from complications within your first year can be as high as 10% to 15%. But obviously, we have to make a bunch of new connections. So there's risks that those things don't heal properly. You can get a leak of bile if the bile duct doesn't heal properly, or if the bile duct narrows down and strictures, you can become jaundiced. Bleeding is a big one. When you have a liver transplant, you're then put on immunosuppression. So you have to take that stuff for life, but you get your highest doses of it right around the time of your transplant. So there's risk of infections of numerous different kinds. There's risk that any one of the new connections that we make can have a problem. The artery tends to be the smallest connection, so there is a risk that it can clot. If the artery clots off, sometimes you need a retransplant pretty quickly. The veins usually have much less of an issue. And obviously, because the liver is coming from somebody else, generally it's not from yourself, there is a risk that your body will recognize it and say, this doesn't belong to me, and I'm going to get rid of it and attack it. And so you can have rejection. And rejection can come in forms that are either acute, meaning it happens quite quickly and early, or it can come chronically over time. It's much less common and much less of an issue with liver transplants than it is with certain other organs like kidney transplants. So, and then there's always a possibility that you put the liver in and it just doesn't work. It doesn't work well. It doesn't do the jobs that it needs to. And then somebody might end up needing a retransplant. Sometimes, in trying to use organs, we push the envelope a little bit and use organs that are they're not like pristine, but they should be good enough, and sometimes they don't work. So if you transplant a liver that has an excessive amount of fat in it, sometimes it doesn't work very well, because the fat, when you store the liver and you put it on in the cold, the fat will then crystallize, and then when the liver gets reperfused, those cells will burst, and then it doesn't work very well. So graft dysfunction or non-function is a possible risk that sometimes requires a retransplant. All right, you can move on. So recovery. So typically, this would be your typical incision for a liver transplant. There are other incisions, but most commonly, these would be the ones that we use. I have one up at the top, so I don't drive a Mercedes-Benz, but I do have their symbol. Typically, right here, we actually do this one here. This is the nice little boomerang. I like that one better, because this one, you tend to get more hernias at. So most of the patients that are done here will get this guy, boomerang incision. So the hospital stay averages between 1 and 3 weeks for most people afterwards, and that really also depends on how sick you are and whether or not you have complications. Do you have some people come in who are getting transplanted for cancer and their liver actually still works very well, and they're in and out of the hospital sometimes in 6 or 7 days. People that are coming in like bad end-stage liver disease and are very, very sick are typically in much longer. So all patients require immunosuppression around the time of transplant and generally lifelong. And then you do require frequent checkups afterwards. You need to get blood work quite often. Usually in the first few months after transplant, you're getting it basically every week. And then that goes down over time. Eventually, you might be getting it maybe once every 3 months. But we need to do that to check how your liver is working, to check whether or not there might be signs of rejection. And that's kind of the recovery after a liver transplant. So, outcomes. So these are Canadian data outcomes. So presently in Canada, 1-year graft survival is, as of 2023, 91.3%, which is actually very, very good, all things considered. And that's just the actual graft working. Patient survival is actually a bit better, obviously, because some people do end up needing to be retransplanted or will survive longer. 3 years is 81% and 5 years is 80%. It wasn't that long ago that those numbers were lower. They were more like 85% for 1 year and 70% for 5 years. So progress has been made. Go on to the next one. So indications. There are numerous different indications for a liver transplant, and some of them have been talked about already. So viral infections, hereditary or metabolic causes, I've just broken these down. Cancer, diseases that cause basically an obstruction of your biliary tract and accumulation of bile within your liver, which can then be inflammatory and cause scarring. Autoimmune diseases where your body is attacking parts of your liver. Acute liver failure from things like Tylenol, and then other acquired or environmental causes. So for viral infections, the hepatitis viruses can lead to liver failure or needing for a transplant. And Dr. Zhu is going to talk about that in more detail, so I'm not going to steal her thunder. But hepatitis B can cause acute liver failure or chronic liver failure with scarring and cirrhosis. And hepatitis B itself is actually quite oncogenic. So it leads to the development of cancers more frequently than the other hepatitis viruses. It's kind of like the leading cause for HCC in terms of viruses, but it's less prevalent than in North America than hepatitis C was. I'll think that's probably changing now, though, to be honest with you. So hepatitis C is the one that we know of that's typically associated with IV drug use or previous transfusions back in the day before we had actual good screening. And it more commonly will cause cirrhosis rather than acute liver failure. It rarely will cause acute liver failure. And then the combination of cirrhosis and hepatitis C puts you at increased risk for development of cancers. And hepatitis A is really only occasionally causes acute liver failure. So I can move on. So hereditary and metabolic diseases. So these are numerous different diseases. Hemochromatosis is an iron storage disease where you have accumulation of iron in your liver that can cause scarring. Alpha-1 antitrypsin deficiency is a protein that tends to work in your lungs, but it's made by your liver, and if it's not able to be exported by your liver, it can cause scarring and leading to cirrhosis. That's the particular disease that I had as a child. Wilson's is related to copper metabolism, and some of these other ones, like tyrosinemia, glycogen storage disease, and these urea cycle defects, they don't actually cause cirrhosis, but they cause big changes with metabolic abilities and quality of life, and often you can replace that disease by transplanting a liver that has normal genetics and significantly enhance somebody's quality of life and also reduce their risk of dying from their disease. Okay. Cancer. So primary and metastatic tumors, both of them have indications for transplant. The number one indication is hepatocellular carcinoma. And so basically your risk of getting hepatocellular carcinoma correlates with having cirrhosis plus or minus your disease. Just the presence of having cirrhosis itself, your risk of developing a hepatocellular carcinoma is between 1 to 3% per year that you have cirrhosis. So every year you have cirrhosis, you got about a 1 to 3% risk of developing a cancer. Fibrolamellar carcinoma is another similar cancer that occurs in non-cirrhotic livers. Hepatoblastoma is a tumor for kids, and it's one of those sarcomas that Dr. Ramsing mentioned. Same with the epithelioid hemangioendothelioma, which is extremely rare. I do have one patient that I follow who has that disease. And cholangiocarcinomas, the biliary tract cancers. And there is they are not like, people do transplant for those, but it's rare and they require a specific protocol. It's usually only done in under studies. Metastatic tumors, neuroendocrine tumors used to be an indication for liver transplant. The most famous person to have received a liver transplant for metastatic neuroendocrine tumor was Steve Jobs. But most centers actually don't transplant for neuroendocrine tumors anymore. Even when people have metastatic disease, for most neuroendocrine tumors, they do have quite a good prognosis with long-term survival, and we probably don't improve things with liver transplant. The immunosuppression probably actually shortens their survival. But colorectal liver metastases is a new one, and we have a protocol here in Halifax. We've done one patient with colorectal liver metastases. We've done one transplant for that. There's a specific stringent criteria. You have to have already had your primary disease out. It has to not have certain mutations. You have to have a period of stability and not have any disease outside of your liver to be a candidate for a transplant. And basically, you also have to have disease that we can't treat surgically any other way other than taking out your entire liver. All right, you can move on to the next one. So cholestatic diseases include diseases which usually just cause scarring of your biliary system and obstruction. Primary biliary cirrhosis and primary sclerosing cholangitis are the two most common in adults. And we have quite a high burden of primary sclerosing cholangitis in Atlantic Canada. We do more transplants for that here than probably anywhere else in North America, basically. Definitely anywhere else in Canada, for sure. And it is often associated with other autoimmune diseases of your GI tract, like Crohn's disease and ulcerative colitis. Biliary atresia is a developmental abnormality of childhood. Ischemic cholangiopathy is actually more a disease related to transplant. So there's certain types of donors that we use. For deceased donors, we use donors that have a diagnosis of brain death, or donors that don't meet the criteria for brain death. But people have to have some form of death to be a donor. So if you don't meet the criteria for brain death, then we have to withdraw care from people. They actually have to die. Their heart has to stop before we bring them to the operating room and then harvest their organs. And so those are called, they change the nomenclature for them every 6 months, but they're called DCD donors, or donation after cardiac death. And those livers often will have a period of time where they've been subject to being at normal body temperature without getting oxygenated blood flow. And your bile ducts tend to be very sensitive to that. So in the early days of using those types of organs, you found that people would get strictures in their bile ducts after transplant quite quickly and need to be retransplanted. So we're very stringent in our criteria for how we go about these, but they can still happen. So, and then some other diseases here: cystic fibrosis, Alagille, and other diseases that can cause cholestatic liver disease. And then acquired and environmental causes. We already had a big talk about metabolic dysfunction, and then alcoholic cirrhosis. So, and these are very similar in pathologically how they affect your liver. So alcohol typically will lead to an accumulation of kind of inflammatory fat within your liver. That's one of the big ways that it causes problems. And so I would say when I started residency, and even at the beginning of my practice, which is not that long ago, the number one indication for liver transplant in North America was hepatitis C related cirrhosis with either cancers or just liver failure from hepatitis C. Now it's that. Yeah. So fatty liver disease is by far, it's the number one, and it's projected to just grow and grow and grow and grow and grow, especially in North America. So with regards to alcoholic cirrhosis, typically most programs in Canada would require people to be abstinent for 6 months prior to listing. That is changing in terms of the big issue with that is it's the addictive process that's the issue. So there are many people that do. We don't keep records, but it's estimated that probably a good 30% of people that are transplanted do go back to drinking. A small amount of those people end up with recurrent liver disease, but it's the addictive kind of the addictions and being able to deal with the addictions. That's more the issue with the alcohol rather than the alcohol drinking in and of itself, in terms of why we want to have time and make sure that we've been able to address some of those issues, and also the ability to make sure that people are compliant with their follow-up, their medications, take good care of a gift that somebody had to die for them to be able to be around still. So, all right, you can go to the next slide. So fulminant liver failure is acute liver failure. It presents much differently than chronic liver disease. Probably the most well-known cause of this is Tylenol toxicity, Tylenol overdose, which can cause massive damage to your liver if it's taken in too much. And so these people, they don't present the same way. They present with acute liver failure, which can lead to them going into a coma, and their liver just basically gets completely necrotic. So these people require a transplant urgently, or else they'll die. Common causes, some of the hepatitis viruses can cause it. Tylenol is a big one. Acute alcoholic toxicity can cause it. It's rare. And then you can have other toxins, mushrooms and things like aflatoxin. So the assessment, how do we evaluate you? So these are the three questions that I would ask, and I think Dr. Zhu would probably also agree with these, is one, are you going to benefit from a transplant? So am I going to make your life better? Am I going to give you a better survival by giving you a transplant? Number two is, will you actually survive the transplant process? It's a very, very demanding process on your heart and your lungs. There's a risk of infections. So I don't want to operate on you if I'm not going to give you more. If I'm not going to give you more time, I don't want to operate on you. And then two, it's a rigorous amount of medication that you have to take. You have to take medication every day, usually twice a day. You got to get your blood taken. You got follow-up appointments. You're at higher risk for developing certain cancers down the road, so you need to have screening for that. So are you going to be compliant with all those things that are required of you? So that's the cornerstones of the assessment. So will you benefit from the transplant? So what's your risk of dying from liver failure? For chronic liver disease, we tend to look at things like your MELD score, which is a fancy way of looking at your labs and helping determine what your risk of death within the next 90 days is. Typically, we would say that your benefit from a transplant operation exceeds the risk of dying from the operation if your MELD score is 15 or higher. And things like King's College criteria are used for more acute liver failure, so that's a different scoring system. So that's kind of how we look at it. Do you have decompensated liver disease? Do you have a cancer that we can't deal with any other way? Those would be the big criteria for, are you going to benefit? So, and then enhanced quality of life. There are some diseases like polycystic liver disease that are never going to cause you liver failure, but people get a liver that's so big that they start getting malnourished. It really have difficult quality of life. And sometimes we will transplant people for an enhanced quality of life, some of those other metabolic diseases in kids. Okay. So can you survive a transplant? So this requires a fairly extensive medical evaluation. We look for any undiagnosed malignancies, so you get full workup that way. You get scopes, checking your GI tract. You get ultrasound, you get a CT scan. We check your heart and your lungs, because when we do the transplant, when I cut out that liver, I'm putting a clamp across that vena cava, and that's interrupting the vast majority of the blood return up to your heart. So then your heart has to work pushing forward not a whole lot of blood, which is very, very challenging on it. And then when we unclamp it, then it gets this rush of stuff coming back. So it's very, very stressful on your heart and your lungs. We got to make sure that your heart's actually going to tolerate it, and it's not just going to crap out as soon as we let things go. So we do a full evaluation, an ECG. We do an ultrasound of your heart to see how it's functioning. Often people above a certain age will get a stress test, so we see how well you do, how much you're going to tolerate physical activity, and sometimes people even need a dye test of their vessels. We check to see how well your lungs are doing. We look at other organ function, like what are your kidneys like? Because when you have end-stage liver disease, it can affect many other systems in your body, including your kidneys. And then what's your risk of infections? Are you immunized for all the things you would need? Are there any undiagnosed infections that we need to make sure are well treated prior to you getting a transplant and getting immunosuppression? Okay. The other things we look at, what's your nutritional assessment? So as cirrhosis is kind of a wasting disease, is disorders in protein handling. So everybody that has cirrhosis, you just recommend to eat a lot of protein. So we want to make sure that you see a dietitian. They get a look at your diet, give us recommendations for things that you can do to improve. And then, are you too frail? So you'll see a physiotherapist. We see what your physical regimen is. we don't want to transplant somebody and then just have them, in hospital for the rest of their life or not able to get out of bed. So we used to have some programs have an age cutoff criteria. I did my transplant training in Edmonton. We typically had an age cutoff of 65 for people for listening for transplant. We do not have that here in Nova Scotia. Okay. But it's really just like we look at, are you going to be able to tolerate it? Typically, most people over 70 with advanced liver disease probably are not in good enough shape to make it through a transplant operation, but we have transplanted people in their 70s before. So we don't do a lot. Most of the people that we transplant are usually in their 50s or 60s, to be honest with you. Okay. Everybody sees a psychologist, and some people, if they do have a history of mental health or addiction issues, they get a bit more of an enhanced evaluation and may have to demonstrate some compliance and going through certain programs. Everybody sees a social worker because often having advanced liver disease is not easy on your financial situation. Obviously, you can't work sometimes when you have decompensated liver disease. You might need a support network. And we'll make sure that you have appropriate supports in your family to help you when you need it afterwards, because it's not easy. You got to get to appointments. You might need people to drive you. And then abstinence, we talked about that already. So life after transplant. So you got to be on immunosuppression lifelong. The amount is the highest initially, and then it comes down afterwards. But honestly, I can tell you personally, taking immunosuppression, I take pills twice a day. That's the biggest impact that has on my life. Yes, it is increase your risk of infections. So you do have to kind of be careful, avoid people when they're very infectious. Try not to share drinks. There are certain foods that you want to avoid, that are higher risk. So things like raw shellfish, that type of stuff, you should avoid. That's not that bad, to be honest with you. It's just pills, and it's not really an issue. You're at the increased risk of infections. We talked about your risk of other medical conditions, kidney disease. Some of the immunosuppression that we take is long-term harmful on your kidneys. So, you have to understand that there is a risk for that. It can cause hypertension. You're at increased risk for skin cancers. Maybe a slight increase risk for other cancers, but really the immunosuppression puts you more at increased risk for skin cancers than any other disease. So there's all those recommendations for sunscreen, covering up, all that type of stuff. It's not, I would say probably about 50% risk at 10 years post-transplant of having had some sort of skin cancer for most recipients. So, and if they're caught early, they can be treated. So, yeah. So why do we do them? It's the only truly life-saving therapy for end-stage liver disease. And it does provide improved health and overall function, and it can allow return to work, recreation time with family. So that's the reasons why we do it. I tell my patients that it's the only operation that I do where I can make you younger. Yeah. And I have some pictures to prove this. So this is me in 2018, okay? So I'd had a transplant initially when I was 14, so in 1993, and that lasted for about 26 years. So this is me in 2018, shortly after starting work here in Halifax. And then this is me in 2019, in hospital with end-stage liver disease. Unfortunately, that graph failed. Move to the next picture. This is initially post-transplant. I was very, 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 very sick post-transplant. Sicker than almost anybody that we've transplanted here, probably. So, and then the next slide. This is me in March of 2020. So I was transplanted in October of 2019. Okay, that's March of 2020. And then last slide. This is me this summer with my kids. So, definitely, I think I look better than I did in 2019. So it's remarkable. It's remarkable when we see somebody with end-stage liver disease, and you transplant them, and they are doing well. You see them a year later, they look 5 to 10 years younger. So it's definitely it's a privilege to be able to do this for people, because I do a lot of depressing stuff. I do a lot of cancer surgery for pancreas cancer and liver cancer, and we try and give people extra time, but oftentimes people still die from their disease. But transplant is very, very gratifying, and we can really do people a service. So I'm very privileged to be able to work here and do that for people. So yeah, any questions, I guess we'll take at the end. Thanks.